let's go ahead and get started. Thank you all for being here today. This is New Mexico Primary Care Training Consortium's first in a series of didactic lectures. We'll be having one each month, which with different specialties, different topics. Dr. Nelson has agreed to put on this first one, and we are going to be talking about opioid use disorder. And then February, we have Dr. Suzanne Berlone coming up with addressing and mitigating maternal mortality. So I will go ahead and turn it over you to Dr. Nelson.
Great, thank you. And thank you everyone for coming to this. It's a little scary being the first to do this, but let's give it a shot. And there's only one way to go from here, and that's going to be up. I'm going to do a presentation. Hopefully it won't take more than 3 or 4 hours to talk about opioid use disorder and treatment. By way of background, I'm a family medicine physician. I've been in practice for about 20 years. I'm also the program director here at Hidalgo Medical Services Family Medicine Residency Program. And been the program director since our development as a residency program in 2013. In terms of addiction medicine and opioid use disorder and substance use disorders, I've been involved in providing medication-assisted treatment therapies since 2018. I got my Data 2000 waiver in April of 2018, and like a lot of providers, I wasn't using it. And then in September or August of 2018, the one provider that we had here in town in Silver City, she left to go back home to Tennessee. And that left us, our community, with nobody providing MAT services. I went from 0 to 30 patients in about a month's time. So it was really quick ramp up for me. And I got to tell you that it was probably the best decision I ever made. I think in doing these services as a primary care physician, it can be really, really rewarding. A lot of people who have the waiver and aren't using it is maybe because there's a little bit of innate fear about the patient population you'd be treating. And I have to admit that I was completely wrong. 180 degrees different. The population that we treat are people who want to get better. They want to stop using illicit opioids. And there's a lot of pleasure that we take when we're able to celebrate 1 month, 6 months, 1 year, 5 years of sobriety with a patient. Those kinds of visits are really, really rewarding. So a lot of this talk is going to be geared towards the learner or the person who doesn't have a lot of experience doing MAT services. Some of these slides are taken from an addiction medicine immersion program that I attended in 2019 that was put on by Boston University School of Medicine. So I just want to make sure that give them credit for some of the information we'll be presenting today. So first, what is opioid use disorder? Which can be different from an opioid dependence or something like that. This is on the screen, the DSM-5 criteria for opioid use disorder. A lot of this can be translated to other substance use disorders like alcohol use disorder or amphetamine use disorder and so forth. Some of the common themes we see in these use disorders are the substance is often taken in larger amounts over a longer period than originally intended. There's a persistent desire or unsuccessful efforts to cut down on the substance. There's a great deal of time spent in activities necessary to obtain the substance, use the substance, and recover from its effects, and so on. I'm not going to read all these to everyone. You can show them on the screen. Once you score each of these categories, you can come up with a severity of mild, moderate, or severe. So the difference between sort of a use disorder and dependence is really meeting these criteria of maybe important social, occupational, recreational activities are given up to engage in that substance use. Whereas dependence is simply if you don't have that substance, you can get some withdrawal symptoms. I'll fully admit I am dependent on caffeine. If I don't get my caffeine in the morning, I'm going to have a withdrawal headache. So my body is physiologically dependent on caffeine. And the same happens with opioids, but I wouldn't say I have a caffeine use disorder because I don't spend an excessive amount of time trying to obtain the substance. Although I guess if I ran out of coffee, I might spend more time than necessary. So that's sort of how we use the DSM-5 criteria to either diagnose opioid use disorder. And yes, they can be in remission. They can be, it could be mild, moderate, severe. It could be in recovery or remission is what we call it. Different levels of substance use disorders, not just opiates. I'm going to zoom out here. So this is sort of the natural history of an opioid use disorder. This blue bar in the middle is sort of a normal range of being. You take the substance and you reach this level of euphoria. You can see that it doesn't take very long for someone who is utilizing an opioid not to reach into this euphoria category any longer. Really, they're when they become tolerant to the substance and physically dependent, they reach into withdrawals when they don't have that in their symptom. A lot of people who have used opiates for some time, let's say a month or more, really never get that euphoria feeling from using the substance. So really, folks that are chronically using opioids are using it so they don't feel sick. They just want to feel normal. That's the whole reason for using it, is to prevent withdrawals and trying to feel normal. This idea about the euphoria goes away pretty quickly in the course of substance use. So we're going to do a little case, and this case will be interspersed throughout the presentation. Normally in a didactic setting, we would have someone read this. I'm going to save everybody the pain of having to find the mute button or the unmute button, and I'll read it myself. 32-year-old male brought in after a, quote, heroin overdose. He had a brisk response to naloxone, the opioid antagonist, but there was resedation after an hour requiring repeat of the naloxone. The patient was also noted to have an antecubital abscess and cellulitis at the injection site, was admitted to the hospital, inpatient setting for drug overdose, persistent altered mental status, and cellulitis. Case continued. This is supposed to say substance use history. We want to obtain that on anyone who has a use disorder. This patient was using about 0.5 gram of heroin a day, started off using it intranasally, and then went on to IV for 7 more years. Had been in recovery for 2 years, had been going to Narcotics Anonymous, but relapsed 3 months ago. Patient has a history of 10 detoxes and no treatment with medications in the past, no other drug, alcohol, or tobacco use. Typical screenings, HIV and Hep C were negative. Patient is an unemployed electrician, lives with wife, who's also in recovery, and 2 young children. Now the patient is complaining of opioid withdrawal. How would we assess and treat him? We would first want to know what level of withdrawals the patient is in, and there are lots of great scoring tools out there. This is an abbreviated one that grades from 0 to 4, the level of withdrawals, with 4 being the worst, with people having vomiting, dehydration, diarrhea, abdominal cramps, curled up body position. Anybody who's seen someone who is suffering from opioid withdrawals, that patients literally feel like they're going to die. They're not feeling great at all. We can do a clinical opiate withdrawal scale. It's another scoring system, which I have on the next page here. I'll zoom in a little bit. So we can use this to this just measures their level of withdrawals. We can also use this score when we begin treatment on patients. 5 to 12 points is mild, 13 to 24 points would be moderate, and 25 to 36 would be moderately severe, and more than 36 points is severe withdrawal. This is something that we can have our nursing staff do on a relatively frequent basis when we initiate treatment for withdrawal. And there are lots of different treatments for opioid withdrawals. So for our patient that we mentioned, our electrician, we have some inpatient goals. One, we want to treat and prevent acute opioid withdrawal. We can't expect to cure opioid use disorder during a hospitalization. That wouldn't be effective. Also, withholding opioids will not cure the patient's use disorder. And giving opioids will not worsen the patient's opioid use disorder. We obviously want to diagnose and treat the medical illness, this one being the abscess on the forearm, and initiate addiction treatment referral so that the patient, when they get released from the hospital, has somewhere to go to continue their treatment. So there's a couple of ways we can treat opioid withdrawals. We can use opiates, full opiate agonists or partial opiate agonists. Methadone would be a full opiate agonist, and buprenorphine is a partial opiate agonist. They are the best choices for treating opioid withdrawal in the inpatient setting. There are some other options, and sometimes we see that this even in our local detention facilities, they use a symptom-based treatment where they're really just treating the symptoms of the withdrawals without offering any sort of opioid receptor agonists. Those include clonidine, tizanidine, which help treat the hyperadrenergic state, NSAIDs for the muscle cramps, benzodiazepines for the insomnia, dicyclamine for abdominal cramps, and bismuth for diarrhea. So here, if we wanted to use a partial or a full opiate agonist, we would use either methadone or buprenorphine. They're both great at treating opioid withdrawals, and they're also good for medication-assisted treatment. With methadone, we start with 20 milligrams. You reassess, and you can use the COW score every 2 to 3 hours, and give an additional 5 to 10 milligrams until the withdrawal signs abate. You want to be cautious about exceeding 40 milligrams every 24 hours. Buprenorphine, this is just how we start the buprenorphine inductions in the outpatient setting. We start with 4 milligrams, reassess I usually do 1 to 2 hours, give an additional 4 milligrams until the withdrawal signs abate, and don't exceed 16 milligrams in 24 hours. Especially with methadone, you do want to monitor for respiratory depression and CNS depression. Little less of an effect of respiratory depression with buprenorphine. That's one advantage of that medication. On subsequent days, you give the same dose each day, including the day of discharge. That allows the patient 24 to 36 hours to get plugged into an outpatient setting where hopefully they could continue their progress. One thing about methadone is we can't give a prescription for outpatient methadone treatment. That is very highly regulated. But we can give a prescription for buprenorphine if that provider writing the prescription has a DATA 2000 waiver. So back to our case, the arm abscess had an incision and drainage. The cellulitis was treated with IV vancomycin. For opioid withdrawal management, they chose to use methadone 20 milligrams on day 1. Come day 2, the patient was very anxious and demanded an increase in methadone. Maybe in this setting, the patient wasn't reassessed for recurrence of or presence of withdrawal symptoms, and therefore didn't get an increase of the dose. The patient was off the floor for 2 hours, and then they had a repeat urine drug test, which was positive for opiates. And the patient eventually left the hospital AMA, which happens all too often in these kinds of scenarios. The patients aren't being treated for their opiate withdrawals. They may be being treated for the acute medical problems. But this patient might have left AMA because they got tired of feeling sick. Just like in that graph we showed before, they don't want to feel sick anymore. So normally in a didactic setting, they ask, the audience to kind of say, what do they think was the cause of that positive opiate on the urine drug screen? Here are some of the reasons that it could be positive. Yes, certainly illicit heroin use during hospitalization could cause a urine drug screen to be positive for opiates. Heroin prior to admission could be a cause of them having a positive urine drug screen, and hydromorphine could be another cause. The one that would not have them be positive on a urine drug screen for opiates is methadone. And that's what this next slide shows. These are sort of your naturally occurring or semi-synthetic opiates. And these are your synthetic opiates, which will come up completely separately on a urine drug screen. So if the patient had heroin, hydrocodone, hydromorphone, oxycodone, or oxymorphone, all those could show positive on a urine drug screen. Whereas if the patient had methadone, meperidine, or fentanyl, that would not show positive on an opiate for a urine drug screen. So back to our patient. This is 6 months later. It presents to our primary care clinic resisting treatment for his heroin addiction. He's been using the heroin since the day he left the hospital. So there are some recommended options for primary care. There's Narcotics Anonymous, which would be an abstention kind of program, abstaining from the substance. There's a symptom-based treatment with the medications we discussed before. There's a full opioid antagonist treatment, meaning naltrexone. It completely blocks the immune receptors and does not let opioids bind to them. So this is a medication that would provide complete blockade of opiates. There's buprenorphine maintenance, which is a partial opiate agonist. And of course, there's overdose prevention and education, and naloxone or Narcan, as we talked about. Other options are detoxification program that could be, in conjunction with an abstinence kind of program. Methadone maintenance, going to an outpatient methadone clinic. I don't know where everybody who's on the call are from. In Silver City, our nearest methadone clinic is Las Cruces. And if you have to go down there every single day to get your dose, it can be quite burdensome, not only on the patient, but on the system also. Buprenorphine maintenance, but you do have to have your DATA 2000 waiver for that. Syringe exchange, that's simply a harm reduction methodology, where if someone's going to continue to use, make sure it's as safe as possible. Acupuncture and outpatient counseling are other options as well. You can use a combination of these too. So here are some of the outcomes from opioid detoxification or complete abstinence. So believe it or not, there's pretty low rates of retention in treatment, especially when we see as compared to methadone or buprenorphine. There's high rates of relapse post-treatment. About 50%, less than 50% remain abstinent at 6 months, and less than 15% at 12 months. So you're looking at less than a 15% retention in treatment from detoxification programs at 12 months. Increased rates of overdose due to decreased tolerance. What can happen in this, and we've seen this in our correctional facilities that do detoxify detoxification process, the inmate is then released, maybe out on bond or parole, or have served their appropriate time. Then they go back and have a relapse and go back to using the same amounts of heroin that they might have used in the past when they had tolerance. The day after discharge from a detention facility is one of the riskiest days for overdose in someone who suffers from opioid use disorder. Some of the reasons for relapse are protracted abstinence syndrome. So it's just derangement of endogenous opioid receptor symptom, generalized malaise, fatigue, and insomnia, poor tolerance to stress and pain, and obviously opioid cravings. And of course, there's always conditioned cues or triggers that our patients have. Maybe it's sort of similar to the person who smokes a cigarette every time after they have dinner. It's just a conditioned cue or trigger. So again, there are some medications that we can use for opioid use treatment. We want to alleviate physical withdrawal, provide some sort of opioid blockade, alleviate craving, and normalize brain changes. So opioid antagonists we talked about already. Naltrexone, completely full antagonist for opioid receptors. Then there's the opioid agonist therapy, methadone, which is a full opioid agonist, and then buprenorphine, which is, as we said before, what we call a partial opioid agonist. So naltrexone, the blockade, it's well tolerated, it's safe, it can last for 24 to 48 hours. You can actually get an injectable naltrexone. I believe the trade name is Vivitrol. It's very expensive though, $1,800 per 100 milligrams. One unique thing is we sometimes use naltrexone in treatment of alcohol use disorder. So if there's someone who has both co-occurring alcohol use disorder and opioid use disorder, maybe naltrexone isn't the best choice. Patients that are physically dependent must be opioid free for a minimum of 7 to 10 days before treatment. If they're not opioid free and you give the injectable naltrexone, the naltrexone will outcompete the opioid for the receptor binding, and you could precipitate withdrawals in that patient. Oral naltrexone is available, although it doesn't have super high retention rate, a little bit higher than the detoxification programs, but 28% of people who were retained in treatment, it's a little better, but not quite as good as opioid replacement therapies like methadone or buprenorphine. This is another study that talked about injectable versus no therapy or oral. And the injectable, you do have higher retentions of abstinence just because it's an injectable. Someone could choose not to take the oral pill for a day and go ahead and go use. This is a study on the long-acting injectable naltrexone. Talked a little bit about 55% of the patients showed up to receive their second injection. Then 32% received their third injection. So as you can tell, as time goes on, the retention tends to wane, even in the injectable naltrexone treatment pathway as well. So this is sort of our goal. This is a graphical representation of our goal in using opioid agonist treatment, OAT, that methadone or buprenorphine. Once again, folks are utilizing substance in order not to feel sick and feel normal. When you engage with someone with opioid agonist treatment, you really maintain them in that normal range for long periods of time. So they don't have to bounce it back in and out of tolerance and dependence, then use, then up to normal. This is really the really defining graph, I think, of why we want to use opioid agonist therapy, is to provide some sense of normalcy. So as we mentioned, methadone is a full opioid agonist. Onset of action is pretty quick. The duration it lasts for quite some time. Sometimes you might have seen out there that methadone is used for pain as well, and the duration of pain relief is a little bit less. So the proper dosing for opioid use disorder is 20 to 40 milligrams for acute withdrawal. It can be 80 milligrams for craving or opioid blockade. When I was a resident way back in the olden days, I did some moonlighting in an addiction medicine clinic, and it was actually a methadone clinic. We had patients there that were taking up to 160, 180, maybe even 200 milligrams of methadone a day, which seems like a lot. You probably, could kill a horse. But when someone has a tolerance, and these folks were functioning people in society, they were chefs in restaurants, and they were accountants and things like that. So the dose is very individualized, and we shouldn't judge that, you're on 200 milligrams of methadone a day, you must be really bad. That's not true. That's the dose that works for them. Methadone treatment does have some of its downsides. It's very highly structured. It has to be in especially government-approved clinics. There has to be a daily nursing assessment, weekly counseling, frequent drug testing, and if it's very, very compliant heavy. In fact, if a patient misses any one of these things, they may be excluded from the program, the ongoing therapy. It works, but it's very highly structured, and it's hard to do, and it must be hard to do as a patient, especially someone who's trying to reintegrate back into the workforce and hold down a job, to have to go every morning to a methadone clinic and pick up and take your dose, which are observed, by the way. You can see this nurse here is holding it almost looks like a liquid. That's because they want to prevent diversion. They want to prevent patients from taking the medication out of the clinic and then diverting it even in the parking lot. So there's been a lot of research on methadone. It's very effective. It does increase treatment retention. It decreases illicit opioid use. It decreases hepatitis and HIV. It decreases mortality, criminal activity, increases employment, and does improve birth outcomes. So methadone's not a bad therapy. It's just very structured and hard to do, and it's really hard to do in rural places.
Hey, Dr. Nelson.
Yeah.
We have some questions in the chat. Would you like to save those for at the end, or would you like me to interrupt? How would you like to do that?
Yeah, let me look at those. I don't mind. I would love to take questions on the fly. So let's see what we have here. Will this PowerPoint be available by link? I can send a copy of this to you, Nicole, and you can send it out.
Perfect.
I have a client has been misusing his methadone, which he gets his month's dosage from the methadone he's going to. He's an outpatient client of our agency. Yes, once you're in a methadone program for a period of time and you've been compliant, you can qualify for what they call take-home doses or take-homes. That does obviously increase the risk of diversion, and it's something that could be going on here. With methadone maintenance, how long will a client need to continue this therapy? That's individualized. And the same goes for buprenorphine. It's a replacement medication. There are people who could be on methadone forever. And same for buprenorphine, forever. I think we look at treatment success as, are they abstaining from using illicit opiates? Are they decreasing their risk to harm from self by not injecting the opiate, by not using needles, by not running in criminal circles in order to obtain the substance? So methadone maintenance can last for a long time. Methadone is very hard to get off of, just like other opiates are. I have had one patient that was going from Silver City every day down to Las Cruces to get their methadone dose, and we were able to successfully convert that patient from methadone to buprenorphine treatment. And that patient is still on buprenorphine, has been on for several years now, but that's okay because the patient is engaging in employment and working and not engaging in illicit activities. So I think that the length of treatment is very individualized and depends on patient motivation. It depends on how soon they want to taper down, if at all. That's great. This question relates a little bit to one of these statements here. There's no ability to graduate from the program from a methadone maintenance program, meaning that, yeah, patients could be on it for a long time. There is a little bit of stigma around methadone and to some degree buprenorphine, and that's substituting one drug for another, which is true. We are substituting one drug for another, but is that substitution providing that patient with a better quality of life, more contribution to society? And if that answer is yes, then I think it's okay. It's just like, I'm substituting a Red Bull for my coffee in the morning. So buprenorphine is another medication alternative for a treatment of opioid use disorder. It's as we said, it's a partial agonist, opioid agonist. It has really high receptor affinity, meaning that it binds more strongly to those opioid receptors than does the opiate. And it has a slow receptor dissociation, meaning it takes longer for it to wear off. Another advantage of buprenorphine is that it does have a ceiling effect on central nervous system and respiratory depression. It's really hard. It can be possible, but it's really hard to give someone so much buprenorphine that their respiratory drive decreases. Whereas it's pretty easy to give someone enough methadone to depress their respiratory drive. It also has a little bit of antidepressant and anxiolytic effects. I do have some patients that are on buprenorphine, or Suboxone is the trade name, and they might report some increase in anxiousness symptoms. If there's room, maybe we can up their dose a little bit and get them some relief from the anxiousness with the buprenorphine itself without having to add another agent. So in random controlled buprenorphine trials, it was more effective than placebo at retaining patients in treatment, at having patients abstain from illicit opioid use. It decreases craving, it decreases mortality, it increases occupational stability, and there are improved psychosocial outcomes. Also, buprenorphine has an improvement on neonatal abstinence syndrome or newborns that are born to moms. It's better to have them taking buprenorphine during the pregnancy than obviously doing heroin. So opioid agonist therapy, not antagonist therapy, does reduce overdose deaths. These are the years from 1995 to 2009. You see, as time goes on, opioid heroin overdoses declined while buprenorphine patients tended to go up. So this is just a graph showing that buprenorphine does in fact prevent heroin overdose. So buprenorphine is a little less effective than methadone in retention, retaining patients in treatment. But I would argue that since it's easier for primary care providers to prescribe and run that program, we probably have a larger impact in terms of number of lives with buprenorphine than with methadone. So these are some of the statements that were taken from that immersion training that I went to. Dr. P was reluctant to obtain a waiver to prescribe buprenorphine for the treatment of OUD until her patient, Miss L, with longstanding OUD, died from a fatal opioid dose. This is something that we hear over and over, and I will echo it. Caring for these patients has become one of the most meaningful parts of practice, and that's true. Providing some sense of normalcy for patients whose lives are roiled by overdose and estrangement is the most profound therapeutic intervention I've engaged in as a caregiver. And then finally, I did not know what Mrs. L meant all those years ago when she said that she only wished she could feel normal again. We talked about that graph and feeling normal and not sick. So when can we start patients on medications for opioid use disorder? And I'll talk mostly about buprenorphine because we talked a little bit about methadone, and it's just difficult you can't prescribe it for opioid use disorder on the outpatient basis. They have to participate in those really structured programs. You can start buprenorphine on the inpatient service, and you can start methadone for that matter. But buprenorphine, you can continue it on the outpatient side as well. There's been a lot of research on starting buprenorphine in the emergency department. So in this study that's mentioned here, that's cited here, initiated buprenorphine treatment versus brief intervention and referral significantly increased engagement in addiction treatment and reduced self-reported illicit opioid use. So I guess the take home is there's no bad place to start buprenorphine treatment. This is how we do it. This is a picture of the actual instructions that we give our patients here at Hidalgo Medical Services. It's very easy, and I sit down in the room with the patient and read through this with them and ask them to sort of repeat it back to me so that we know they understand. So before taking the buprenorphine, you want to feel as lousy as you can from withdrawal symptoms. That's going to be one key to starting the buprenorphine. It should be at least 12 hours since you last used heroin or pain pills, and at least 24 hours since using methadone. I'll come back to that methadone in a second. The worse you feel when you begin taking the buprenorphine, the better it's going to work. It's counterintuitive, but it's absolutely true. So I tell my patients, and most patients know what these symptoms are. For me to sit there and think that they've never experienced withdrawals if they've been a heroin user for the last 5 years would be ridiculous. So they know all these symptoms. You want to have at least 3 of them before you take that first dose of buprenorphine. And again, the more you have, the better you'll be. You start with an 8 milligram film. These are all dissolvable films that you place under your tongue and allow them to dissolve. You cut it in half, and that makes you 4 milligrams. You put 1 strip under your tongue, don't swallow it, and keep it under there for 15 minutes. And that's it. You wait for about an hour and see how you're feeling. If you're feeling good, great. it's working. If you still feel lousy, you still have some of these symptoms, go ahead and take another half. That's okay. After you've taken that second half, if you needed it, you wait for 6 to 12 hours. If you're still feeling lousy, take another half. The most you should take in the first day is 16 milligrams. So don't exceed 2 strips in the first day. On the second day, you take the exact dose all at once that you required for the first day to feel better. So if you took 3 halves, you took 12 milligrams, that's your dose on day 2 and day 3. Usually after we do an induction, almost all of our inductions are home inductions. Usually after after a home induction, I'll see them within 2 to 3 days to see how it went, assess how much they needed to take to feel better. If they took all the way up to 16 milligrams and still felt lousy, I'd want to see them more frequently so we can adjust the dose. You can go higher than 16 in a day for maintenance. It's just not recommended starting off an induction at higher than 16 milligrams in 24 hours. The comment on methadone, the patient that I had converted from methadone to buprenorphine, that patient was on 90 milligrams a day of methadone. If at all possible, we want to get those patients down to 30 milligrams a day before we convert them over to buprenorphine. This patient had had their last dose of methadone on a Monday, and I didn't start the induction process. I initially brought the patient in on Thursday to do a COWS score, and the patient wasn't scoring high enough on the COWS score to warrant induction on Thursday. So I waited till Friday, had the patient back in the office. It was scoring about a 12 or a 13 on the COWS scale, not too high. Remember, over 36 is severe withdrawals. So this was scoring about a third of that. Waited for a couple more hours, and then once we reached a score of 15, went ahead and decided to start the induction. Gave him 4 milligrams, waited an hour, was still feeling kind of horrible, gave him another 4 milligrams. Felt like that was enough to stop at 8 milligrams a day. Sent the patient home on Saturday. The patient got up, took their dose on Saturday morning of 8 milligrams, and went into precipitated withdrawals. Fortunately, the patient continued on with the therapy and has been successful with buprenorphine ever since. But the point is, methadone is, it's hard to get off of. It lasts for a long time in the body. It's got a long half-life. So even in waiting 4 or 5 days before starting the buprenorphine, we still had some precipitated withdrawal symptoms, which could lead to what I call a false start or a failed induction on buprenorphine. I'm going to zoom back out here. So 2 years later, the patient that we've been talking about has been successfully treated with buprenorphine / naloxone. That's the Suboxone. At 16 milligrams a day. The patient presented to the ED today with a fibula fracture sustained while playing soccer. How would we manage his acute pain? In patients who are on MAT and they have acute pain, and I see it all the time, patients of mine that are on MAT, and maybe they go get a hip replacement or knee replacement, and all the orthopedic surgeons are afraid of Suboxone, and you just have to, no, we don't stop it, we keep it going. We just know that it might take a little bit more of the opiate pain medicine to relieve their pain, in acute pain. So in treating acute pain on patients who are on opiate agonist therapy, continue the Suboxone, continue the buprenorphine, and treat their pain as you would anyone else. If someone's in pain, we need to treat it. So patients who are physically dependent on opioids, like methadone or buprenorphine, must be maintained on a daily equivalence before any analgesic effect is realized with opioids used for acute pain. Once again, continue the Suboxone or buprenorphine, treat the pain as you would any other one. And I just did a pre-op for a patient that's a MAT patient of mine that's going to have a hip replacement soon. And in that note, I wrote that, the risk of mortality or morbidity from the proposed procedure is low. However, please note the patient is taking buprenorphine at this dose. It should be maintained, and they may require a little more than usual of pain medications in the recovery period. So opioid analgesic requirements are often higher due to increased pain sensitivity and opioid cross tolerance. So just keeping that in mind, we don't stop the buprenorphine and we treat the pain as we would anybody else, recognizing that we might have to give a little more. There's a question here, is OAT available for individuals who are incarcerated? Locally, it had not been, but recently at our local detention facility, they are starting to do MAT or OAT therapy. Right now at that detention facility, they're only continuing the buprenorphine for patients who are brought into the facility and are already on it. So they're not doing any inductions. It really depends on the locality. When I was in Boston for that immersion training, their prison system actually had a methadone clinic in it, and buprenorphine was common. It seems that the farther west you come, the less common it is. I think that doing OAT in detention facilities is a great harm reduction. If not for when that person gets out, is released, they are much less likely to seek out illicit forms of opiates if they already have buprenorphine on board and have a prescription for it. I know that was quick and a little bit fast. I do have one sort of comment about opioid use disorder and perceptions that we have. And I've heard it, maybe even thought this myself, and that is, well, that person, made the choice to use heroin, and now we have to treat them because they made that choice. And that might be true, that they made that choice at some point in time, at some point of distress or whatever. But I can pretty much guarantee you that I'm sorry, I get really passionate. That many people who struggle with opioid disorder might have made a choice in time, but I can guarantee that they didn't choose to grow up homeless. They didn't choose to be abused as kids. So when we treat people who are suffering from opioid disorder, let me just encourage you all to sit back and reflect on all those social determinants that might have led them to where they are now. And I'll end by saying that, yeah, that's true. I see a question here. Over half of OUD clients started with legal opiate prescriptions. Absolutely true. Yeah, maybe they didn't choose to break their leg and get dependent on opiates. Taking care of this population has been a true honor, to be honest with you. It's something I'm very passionate about, and it's something I know that primary care has a place. We as primary care providers have a place in helping solve this opioid crisis in our country, especially in rural and frontier areas. We're already resource thin, so we need to have a cohort of primary care providers that are willing to do the hard work. And I can just tell you, man, the rewards are immeasurable. So I think that's all I have. I'll be happy to take any questions. I know this wasn't, a super scientific presentation. This is really kind of a day in the life of me in a rural area. There are great resources. UNM Project ECHO has a great OUD ECHO program, which you can do weekly presentations or attend weekly presentations. There are lots of resources for people who are out there thinking about helping this population. Are there any questions?
Well, I do have a kind of a weird question here, Dr. Nelson. So I have a patient who wants to get off alcohol, and at the same time, he's also on MAT treatment. I know naltrexone is kind of one of those first-line medications that you would take. So what would be a good alternative for them? Because based on your presentation, that's a pretty long time, at least 6 days before they can even think of using naltrexone, and I don't even want to take them off bupe.
Yeah, you could try some of the medications that we've commonly used for alcohol abstinence: disulfiram, metronidazole. There are a couple of others that, those like disulfiram, commonly known as antabuse. If you take it every day and then you drink, you get really sick. The same thing happens with flagyl. It can happen with flagyl as well. So taking those medications along with buprenorphine is completely okay. So you can get some I guess, alcohol use deterrence with those medications like disulfiram, and at the same time have that opioid agonist function that you're getting from the buprenorphine. You're right. You're utilizing naltrexone in someone who struggles with both alcohol use disorder and opioid use disorder might not be the best choice.
Thank you.
Well, thank you, Nicole, and the New Mexico Primary Care Training Consortium. I've always been happy to do things like this where we can get out to a number of different people in different places, and hopefully we're able to share something that that was useful in people's work and daily lives.
Yes, thank you so much for being our guinea pig. We really appreciate it.
Well, hopefully people will want to continue to attend instead of the opposite.
I am sure. And Mario, you guys will see, is putting some links in the chat, one for a feedback from today's lecture, and then the other link is for registering for next month's presentation. I want to thank you all for being here, and just stay on the lookout for our future communications with you all.